Well, good afternoon, everyone. We're going to go ahead and get started. My name is Mike Romersky. I'm the superintendent of Hempfield School District, and we're pleased with our partnership that we have with Penn Medicine Lancaster General Health to bring you COVID-19 in schools. I do want to again acknowledge the partnership with Penn Medicine LGH. We're very grateful for this collaborative partnership that we have where they're able to provide us the medical consultation as we work to reopen our schools. And at the same time, we're also grateful for our county commissioners who provided the additional funding through federal CARES dollars to make this partnership happen. So we're greatly appreciative of both our commissioners and Penn Medicine LGH for being willing to work with all the school districts in the county. And so today we have Dr. Jeffrey Martin, who is the chair of the Department of Family and Community Medicine, as well as the medical director for Lancaster County's contact tracing program. He's with Penn Medicine Lancaster General Health. So at this time, Dr. Martin, I'll turn it over to you.
Great. Thank you, Mike. And thanks everybody for having us again. This is the second in a series of webinars, and we'll probably be giving several more of those. I also want to acknowledge my appreciation to Mike and his leadership around trying to unify and standardize the approach to COVID in the schools, as well as to IU13 and the county, who's kind of helping fund this effort. And I'll get into that whole proposal at the end of the presentation so that folks have an idea of what we're trying to do. So I'm going to stop my video and I'll just continue talking. So today, what I'd like to do is start with the question that's really difficult to answer, and that is it safe to open up schools? Sometimes it makes sense to go after a question that is in some ways unanswerable, but I'd like to provide a framework for folks on the call to think about safety and to think about risk, both individual and corporate risk. I'd like to share a little bit about the current state of COVID in our county. I'd like to review some of the current Pennsylvania Department of Health, as well as the Pennsylvania Department of Education recommendations, and finally end up with how this process is going to work going forward. So I'd like to start just by saying that much has been said and debated about the appropriateness of opening schools for in-school education. There are certainly risks to opening and risks to not opening, just as there was about opening other areas of our community, like businesses and other congregate settings. And when I use the term congregate settings, I'm talking about any place where people gather in high density populations like shelters and nursing homes. As you know, opinions cross the spectrum and in reality are often driven by individual perception of risk. As an analogy, we can use the local nursing home experience. For those who are not connected to nursing homes, who don't have a family member working in or a family member who's a resident in a nursing facility, and who may view them as closed settings, the perception of risk seems quite low. In fact, many have questioned if we should include nursing home cases and deaths in our reporting of COVID metrics for the overall community. On the other hand, for those with family who work or who are residents in nursing homes, the risk seems quite high. In fact, despite the lockdown of our county nursing facilities early on in the pandemic, many cases and deaths have still occurred, producing an incredible toll in lives, mental health, and the workforce in general. It seems plausible that since nursing homes were locked down, that COVID didn't start there. It came into them from the outside, possibly by an asymptomatic staff member who unwittingly introduced COVID into those facilities, unfortunately with disastrous results. But what is clear, and what will be similar to our opening of our schools, is that there really are no closed settings. Staff come and go, interact with the community and their family on a regular basis, along with others at their place of work. Students obviously also come and go and interact with family members and community. So in other words, what is going on in the community with regards to COVID will affect any congregate setting. And this even applies to prisons. So my feeling is that we can't exclude cases from any setting, as it will further hinder our effort to understand what is going on in the broader community. I was pleased to see the new DOH regulations with regards to opening schools and how to respond to outbreaks being tied to the amount of spread of COVID in the community. As community spread goes, so does spread in congregate settings like schools, nursing homes, and shelters. It is why we need a coordinated response between contact tracing in schools as well as with contact tracing in the community at large. And we here at Penn Medicine LGH, along with the school districts, have developed an approach that comprehensively deals with the nature of the pandemic that we find ourselves in. So, what is the answer to is it safe to open schools? Well, it's complicated and it depends on a lot of factors. And I would like everyone to move away from broad statements about whether it is or is not safe to open schools, because I think that misses the point. As safety depends on many individual and community factors, some that are in our control and others that are not. We can lose sight and frankly, the respect of others who don't share our particular viewpoint. On top of that, we are only 6 months into a novel, meaning new, virus that we continue to learn about, and we need to give ourselves some room for making decisions that are deemed inappropriate at a later date as new research comes out. I think that we can help alleviate individual and corporate anxiety if we try to validate and respect these differences in actual and perceived risk, and think about ways the community can respond in a nonpartisan fashion that values all members of the community. So what I'm proposing is that rather than broad-based declarations about safety, is for persons, families, and communities to go through a risk exercise as a way of understanding their individual and community risk. So let's unpack some of these issues a little bit. So a risk assessment exercise like this is not unlike what you might experience when going to a doctor about a perceived or factual risk based on your current health status, family history, ethnicity, and social determinants of health. Social determinants of health are those issues that we separate from biologic factors like housing and food security, financial well-being, social and caregiver support, and access to quality medical care. In fact, we are slowly discovering that it is these social determinants that actually define and drive risk well above your genetics, family history, or current health status. So let's start with the health-related risk. And I would encourage you to just kind of make a mental tick if you find yourself in a high-risk group in each of these subtopics as a way of understanding your own personal safety to measure it as it relates to schools opening up. Obviously, if you don't have these risks, you don't have to make a little mental tick mark. Eventually, I'm sure somebody will come out with an algorithm that defines this for folks. But what do we know in terms of health-related risk? We know that chronic disease and disability, particularly diabetes, underlying cardiovascular, pulmonary issues, obesity, smoking, and I would add vaping to that, and being immunocompromised are definite risks to having severe complications related to COVID. The upper chart on the right shows you the increase in hospitalization rates related to people that have these chronic conditions. So that if you have an underlying condition, you're more likely to be hospitalized than if you do not. Only 9% of folks who we see in the hospital have no underlying condition. We also know that age is quite important. Children ages 0 to 18 are by and large at a much lower risk than older folks, but that risk is not zero. In fact, we've not seen any hospitalizations due to COVID here at Penn Medicine LGH, but that doesn't mean that kids can't get seriously ill, and I know there's concern out there about the multi-system inflammatory syndrome in children, for which there's been about 20 to 30 cases in Pennsylvania. Risk of serious illness increases significantly if you look at the lower chart on the bottom, and it shows you the hospitalizations per 100,000 based on different age groups. So when you hit age 60, your risk starts to go up significantly, and of course, age and chronic disease often go hand in hand. So there's overlap there. What about race and ethnicity? We know that non-Hispanic Black persons are affected disproportionately than non-Hispanic whites. And why is this? Well, we don't really know for sure. Studies are ongoing, but probably reflect disproportionately higher chronic disease, social determinant of health issues, and working environments. And you can look at the chart from the CDC on this slide, and it shows you that the percentage of populations, although lower for non-Hispanic Black folks, even though it's a lower percent of the population, there's a higher percent of hospitalizations. So what does this mean for schools? Well, it means that school districts with diverse populations may be at increased risk to opening than those who are less diverse. But there's also a risk to not opening these schools because it may further exacerbate some of the current racial inequalities that we know do exist in education. What about mitigation measures? So one way to define risk is to look at how we are social distancing compared to other counties, and I'll present a slide after this one that shows you where we're at. What about masks? Is everybody wearing them? Is it the right kind of mask? And we know that masks that have valves or masks that are knitted or the gaiter type neck mask might not be appropriate and may actually be involved in more spreading of the small droplets that I talked about on the first webinar. There's some small studies that need to be replicated, but at this point, you know, a cloth mask or a surgical mask is really the right way to go. Are we wearing it correctly? Is it covering the nose and the chin? Is there gaps in the sides? And what about face shields? Well, we don't really know about face shields. We know at least probably in a hospital setting, if you're around people with COVID, a mask with a face shield will help mitigate your risk further. But we don't have a lot of studies around just face shields by themselves. So we don't know if a face shield is equivalent to a mask. And so at this point, the CDC is not recommending just face shields. What are people doing in the community? And this big chart on here gives an assessment of some risk assessment around certain behaviors that people engage in the community. Much of the time, it's not where you go or your individual risk, but what you did when you went there. So can you travel to a hotspot? Probably. As long as you stay in the location that you find yourself in and you don't go visit restaurant or bars or do all the things that we like to do on vacation, and you may still be in a lower risk category. There are clearly defined risks for yourself and others based merely on what you do or what activities you engage in. So if you're engaged in a community high risk activities, you know, give yourself a point. If not, take away a point. So some of these community activities are avoidable, like large gatherings, but some are not, like seeking medical care or going to the dentist. So what's happening with our social distancing? This data is from CHOP crowdsourcing data, and I have a link on there if people want to get on that. This is data that reflects travel to non-essential businesses using publicly available cell phone data. And what it looks at is a comparison of where we were compared to 7 days prior, so the week prior. Anything that's positive is good. So Lancaster is at 13%. So that means we have 13% more social distancing, if you believe this data, than we did the prior 7 days. However, when you compare that to other counties in our region, such as Berks, Dauphin, Chester, York, and Philadelphia, we are a little bit behind. I'm not sure why this is, but I think it is an interesting risk factor that is inherent in the community. So what are the public and community health measures that are in place in our county? We do not have a county public health department. But we have begun engaging in many activities from a public health nature. The key one of those is contact tracing. We are tracking metrics that compares well to other regions. And if you look at the percentage of cases that we actually can get a hold of and interview, we're at 71%. And if you look at the percentage of contacts that we're able to reach and give quarantine advice to, That's 62%. And it compares very favorably to Maryland and New Jersey, states that do have contact tracing up and running and that do report their metrics, but not many states do. The target for both of these metrics is considered 80%, and we're working hard to get there. We have forged close relationships to those at the State Department of Health. So although we do not have a public health authority, we can get a hold of people in a very quick time frame, and we have regular weekly meetings with many folks from Department of Health. And we have many providers that are working in schools as sports physicians and district medical providers. This is not typically thought of as a public health action, but in a lot of ways, we care, Penn Medicine LGH cares for a lot of the folks in our community on a lot of different levels. And we've been thinking about creative ways to leverage that involvement for our county. In short, I think we are doing pretty much everything we can without a local health department. We don't have a complete data set of all the cases. We are working with partners like WellSpan and Lancaster Health Center to get more of the cases that are circulating in the county to make sure that we're able to contact trace all those that have developed COVID in our community. So short of that, I feel like are doing pretty well. Also, I think in terms of risk assessment, we need to look at our ability to keep testing turnaround times at 48 hours. So I mentioned a lot of this on the previous webinar. I won't go over all this again, except to say that we're working very hard to even out the variability in testing. We're attempting to pull in more testing capacity, both by looking at large corporate labs and also by bringing more testing platforms in-house. And I'll just say that there may be newer tests on the horizon that are quick. You can get a result in 15 minutes. They're antigen tests, but they're less accurate than the typical swab test that we have been doing for most of the pandemic. But then the question becomes, can we sacrifice accuracy with overall more testing? And this is going to be something that will need to be defined by our epidemiologists and other colleagues to say, if we can increase the amount of testing, is that actually going to help us decrease the spread of COVID in our community? And I also think that we are scattered throughout this county. So you see the school districts on the right. The left is a location of Penn Medicine LGH service sites, including our hospitals and outpatient and physician practices, as well as urgent care and LG Express. So we model pretty well where people live and work in our community. And we are trying to leverage all those locations in order to help out with the current COVID crisis. Now, there are some things that in terms of risk are difficult to define. So what are the risks for not opening school? There's obviously risk to children who may miss meals and supportive environments. There are risks to adults who rely on school so that they can work. And there's a risk to our community as a whole, where public education is a fundamental tenet. What are the risks for schools and opening all of society at the same time? It obviously becomes more difficult to continue to open, decrease mitigation measures, and have people go about their regular or normal businesses activities pre-COVID to people in congregate settings. What is the risk to a family member who has significant risk factors? So even though you may not, what if you live with someone who's elderly or has chronic disease? These are all things that we can help mitigate. When the pandemic started, I wore a mask at home. I sat at a different table than my family. I did not want to potentially infect them. And of course, we were very careful about visiting or being around any of our in-laws who were elderly and had some chronic disease. And finally, what about perceived risk? if you're a person who has had a family member die of COVID, your understanding of risk may be very different than someone who has not been personally affected by that. And again, I think we need to respect and empower people's perceived risk as it comes to opening schools. So where do we stand currently? I put up the early warning dashboard from the Pennsylvania Department of Health. They are modeling the rate of cases per 100,000 residents over 7 days. We currently stand at 58.7, and that's up a little bit from last week. They're also modeling the positivity rate of test, and that's gone down a little bit over the past 7 days, and currently at 4.5%. On the right graph, Lancaster is the orange line. The blue line is the average of PA. And so you see a lot of counties that are kind of clumped right in this middle area. So we're not an outlier. We're not doing bad. We could be doing better, but we've kind of been in this plateau period for a long period of time. So what is the Department of Health and the Pennsylvania Department of Education saying? So Lancaster is currently at an incident rate of 58.7 and a percent positivity of 4.5%. We need to be less than 10 in incidence and less than 5% positivity to reach a low level of transmission. So Department of Health is defining the different risk categories based on the level of community transition. So we're currently in this moderate category. It's likely, not due to our percent positivity rate, but because of our incident rate, that we will be in the moderate level of community transmission for some time to come. I don't see this changing dramatically over the next few weeks to months, and in the short term, we'll probably stay in the moderate category. Being in this moderate category triggers certain public health actions by Department of Health. And it also defines for us the type of instruction that's recommended. However, it's not mandated. And I put a Excel link that the state is putting out that shows exactly where our county fits in terms of this low, moderate, and substantial metric.
Dr. Martin, if I could just jump in really quick,
Yeah.
Can you go back one slide?
Yeah.
I just want to clarify something for all of our attendees. We've received information from the state regarding the moderate and the blended option. And people jump right away to blended meaning hybrid, and that's not necessarily the case. And so blended learning and what is being reported to us on the school side is, yes, hybrid is one of those options, but what we need to make sure is that if we're in low, we can offer full in-person. But if we're in the moderate, we have to offer multiple options to work to reduce the number of students in our schools. So that could mean you could offer in-person, you could offer virtual, you can offer a hybrid, you can offer all the varied options. And so that's really what that blended learning model means. But what's being reported at times is it's just a hybrid approach, and that's not the case. So I did just want to clarify that.
Yeah, thank you very much for clarifying that. And then DOH and the Pennsylvania Department of Education have put out guidance about when to close schools. And again, in the moderate category, it's dependent on the number of cases within a 14-day period, and you can see what happens or what the recommendations will be from the Department of Health. You know, personally, I think this aligns with what's going on in the community. And since we don't have data in our county that can show us directly what's happening in that school district, this approach does reflect what's going on in the community, and it does seem like a reasonable approach. So you can argue, I think, either way, whether this is appropriate or not appropriate, but where we find ourselves without having the granularity of data down to school district level, I think it's a reasonable approach, but it also means we have quite a bit of challenge ahead of us. Department of Health has also put out guidance around what do we do with symptomatic patients. And we are committed here at the health system that, and we realize that as schools open up and as we get into the winter season, that not all symptoms will be COVID. And we are strongly encouraging our primary care base, our family doctors and pediatricians, to use their clinical judgment to be a force in our community to understand if someone presents with symptoms, is this COVID or is this not COVID? There's going to be plenty of things that come and go as we've had over in the community in prior winter months that are obviously not COVID. And in those cases, we don't need to test those folks. In those cases, we can give a letter that says it's okay to return to school after you're afebrile, for instance, for 24 hours. So we are committed to just not testing everybody, but to really test smart. And if someone has a rash, or someone has strep throat, or someone has something that's specific to another virus that's not COVID, it's okay for us to use our clinical judgment and to write a letter that says this person's okay to return to school. So hopefully that alleviates some fears. So how will this whole interaction between the schools, the county, IU13, and Lancaster General work? It's funded through CARES Act dollars from the county, and it involves the following activities. We are going to develop key contacts and liaisons to be able to answer questions as they arise from school. We've already been involved in this in some cases on Sunday at 6 p.m., which is not a time that anybody wants to get a phone call, but we are able to work through the issues. We want to provide access to providers and specialists in our health system in infection control, sports medicine, testing and contact tracing, occupational medicine, and so forth, to give us recommendations and filter what CDC and PA, DOH are telling us. We will standardize all the protocols consistent with CDC. We're not going to make protocol development that's outside of those recommendations. We are developing a list of frequently asked questions that can be accessed and updated as recommendations change. And we're going to provide educational venues like this one with medical experts across our health system to hopefully help everybody understand what is going on and how we mitigate spread of the virus. And we're also engaging in on-site walkthrough assessments at the schools to provide guidance and direction on actions to help schools mitigate risk. In short, what we're trying to do is leverage our healthcare system, including our primary care providers, essentially to fulfill our fundamental mission, which is to advance the health and well-being of the communities we serve. And I think we've done a pretty good job at getting there. So our community has come together and developed an integrated educational and response system that meets the needs of our schools, residents, and community. The county has stepped up to help us do this work. The schools are engaged, including Superintendent Bromiski and Hempfield, but all the school districts have signed on as partners with us. The IU13 has helped to coordinate, especially with PPE and other issues that are important to schools. And we at Penn Medicine LGH will leverage all our resources to be available, guide, and distill information. And we've developed educational resources and protocols. So I see this as a multifunctional engagement. We will take experts from the hospital side that will help us work with Department of Health and distill guidance, but we also have school-based health clinics and sports medicine physicians and our extensive primary care base that interacts with all of you in the community. So this is very much a back and forth. It's very much integrated, and I think does a lot to mitigate risk in our county. So this is just a screenshot of some of the resources that we've already produced. We're updating this on a daily basis as new guidance comes out. We're updating our protocols. And this is something that the school districts will have access to in times of need. So I'll end there. Thank you very much for listening. I hope I didn't produce more questions than answers. Sometimes that happens. I hope I provided you a fundamental groundwork for how you can determine risk. And my goal is really to empower us all to think about what opening schools means for us individually and corporately. And I'm continuing to be heartened daily by the way that the Lancaster community has come together to really solve the daunting problems we face. And hopefully we'll move the discussion beyond yes or no and more into a discussion of, well, what are the risks and how can we deal with those risks as they are presented to us. So again, thank you very much for allowing me to speak, and I'll take any questions.
Great. And so so all of our attendees, you can certainly use the chat box and post those questions. And as they're coming in, Dr. Martin, I'll just start with one for you. Knowing that you're leading up the contact tracing team, and the question that's coming in at this point is, what will that look like for schools? Like, who will be the primary contact for the contact tracing, or if communication needs to go out? We know we'll be working with the Department of Health, but who specifically, will Penn Medicine LGH team members be looking to connect with? Is it the certified school nurses, the principal, someone else?
So we are defining a process on our end by which an identified person from the schools will have access to 24/7. DOH has specifically said that they want to be involved in contact tracing in the school. We have firmly carved out the space for community contacts. So those are clearly defined. The issue at times comes in where if one of our providers orders a test, they're watching their in-basket in the electronic medical record closely to see when that test has resulted. And oftentimes we get the result of that test prior to it being given to Department of Health, although there's an electronic interface, so they should get it quickly as well. But there are times where locally we can respond quicker with some guidance. So we have decided that there will be times when we may need to make quick decisions without having DOH fully investigate the case. These may involve quarantine of sports teams. They may involve quarantine or isolation of specific cases. But the caveat is, when DOH does do a full investigation of that case, they may change the guidance that we give. But I think that in many of these instances, we may be able to give guidance hours, days quicker than what you may get from DOH. And we may err on the side of caution. If the risk of canceling a practice for a sports team seems low, if there's a potential case in that sports team, that may be something that we would recommend. Again, with the caveat that Department of Health may change that guidance when they get to the case investigation 2 days or hours or days later. So it's kind of a tricky dance right now, but our feeling is that we do have an ethical and moral imperative to act quickly if we see a situation that seems dangerous.
And then a question that has come in, where are we able to access the forms you showed in the presentation, such as the printables for health rooms and classrooms? That I can actually answer very easily. All the superintendents across the county have been working and collaborating, and they all have the link to this particular Google Drive where we can access the information. So every district is working with their teams to determine how they're sharing that information out. So if you are in one of the 16 school districts, I would reach out to either your building administrator or district administrator to inquire about it. If you have questions there, if you're one of our non-public partners, the schools are working to provide that collaboration, as well as the IU is also forwarding information out to the administrators of our non-public schools.
And I would just add that we are in the process of engaging our primary care base as well, our family doctors and pediatricians, so that they have access to the standardized protocols. Again, it's about trying to keep messages on the same page. It's about trying to standardize the approach so that we don't have one-offs occurring all over the county when schools open up, and we're committed to doing that.
All right. I don't see any other questions coming in, but Dr. Martin, I do thank you. I thank you for the approach to the question of, is it safe to open schools? And I think looking at it from not only a risk mitigation standpoint, but kind of that risk factors, as you talked about, kind of a risk assessment is very critical. And again, we're just really appreciative of the partnership, the willingness to plan together, be able to answer those questions for schools, and to determine next steps and taking things one step at a time. So thank you for your time today. One more question just came in. Is there a simple mask cleaning guide you are directing folks to use? They're concerned about the lack of cleaning of the masks being done at home?
Well, we can take that question and talk about it. Just offhand here, I think it depends on the type of mask that you're using. Obviously, it's hard to clean a regular surgical mask versus a cloth mask. We have engaged in cleaning N95 masks through a process in order to try to save PPE. So that would be a question I guess I would have to take offline and pass around to our folks in this collaborative process and try to come up with a recommendation.
All right, Dr. Martin, thank you for your time today, and thank you for all of the attendees who are joining from across our county. We greatly appreciate it, and we'll be offering this session again Friday morning at 9:30. So have a great rest of your day.
Thank you very much, everybody.